Well, good afternoon and welcome to this workshop on the management of fecal incontinence from bench to bedside. I'm Donna Bliss, and I'm the chair of this session, and I have a few housekeeping items to read. We do ask that you please complete the evaluation for this session. There are a few paper copies around the room, but you can also complete the evaluation through the app this year if you've downloaded the app. A shortened version of the handout has been provided on your way into this room, but full handouts of all workshops are available via the ICS website. We ask that you please silence or turn off your mobile phones. We ask that you please do not take photos of the slides that are shown during this session. As we said, the material that the speakers wish to share is available on the ICS website. And if you have any problem with the temperature of this room, to please let one of our attendants know, and we can adjust it for your comfort. So those of you who are currently coming in, welcome. And so I'll be doing the first presentation to give an overview of the conservative therapies for fecal incontinence related to lifestyle and self-management. Julia Herbert, who's a consultant physiotherapist, will discuss the behavioral therapies. Holly Richter, a surgeon and professor of obstetrics and gynecology, will explain surgical approaches. And Masarat Zucchi, a colon and rectal surgeon and associate professor of surgery, will update us on cell-based therapies. Here you see our schedule. Julia and I will take questions after Julia finishes presenting, and similarly, Holly and Masarat will take questions together at the end of this session. Here's my title slide. For my disclosures, I have a consulting agreement with Domtar and receive travel expenses and an honorarium for a conference presentation from Hartman. So the 6th annual consultation on incontinence and the ICS identified and defined 4 types of bowel incontinence: anal, fecal, flatus, and mucus incontinence. You see here anal incontinence encompasses all of the other types, and the definition of fecal incontinence was revised more simply to be the involuntary loss of feces. I think it is worth noting that when discussing the evidence about the effectiveness of therapies to reduce the severity of fecal incontinence, that 7 of the 8 commonly used severity tools actually measure anal incontinence, or a combination of anal incontinence and quality of life, but currently no instrument measures or scores the severity of fecal incontinence only, or fecal incontinence separately from anal incontinence or quality of life. And so the Committee on Conservative Management for Fecal Incontinence recommended that a quality of life, that the quality of the evidence would be improved by having such a score. And all this slide is showing you is that the conservative approaches that I will mainly be addressing are among the initial interventions here recommended in the algorithm on fecal incontinence management by the ICI-6 ICS consultation. Those are those listed here in the green box. And I'll also be discussing a couple of the secondary interventions on products and devices. So patient education and advice are important parts of conservative management. Studies show that many individuals and their caregivers have low continence literacy. They need and desire information about normal bowel function, possible alterations that are creating their fecal incontinence, management strategies, and their individual management plan, and various treatment options. And the effectiveness of educational approaches for patients with fecal incontinence is now being tested. One recent study examined if teaching women a mnemonic would help them remember what to do for their treatment plan better than the usual approach of advice with written resources. And results showed, unfortunately, that there was no significant difference with use of the mnemonic versus usual guidance. However, patients in both groups had higher satisfaction with their care program, and this was attributed to providing education and advice. Considering a patient's goal for treatment is another cornerstone of conservative management. Patients can achieve some satisfaction even if fecal incontinence is not completely cured. And interviews with community living men and women with fecal incontinence showed that their top 3 goals of management, if they were asked if complete cure could not be achieved, are listed here. A decrease in the frequency of leakage, a decrease in the leakage of loose or liquid stool, and greater confidence in controlling fecal incontinence. So those of you currently in practice, I'm sure you've come across these objectives and goals of your patients similarly. Conservative management for fecal incontinence includes advice on possibly modifying dietary intake, as some individuals report worsening of their symptoms after eating certain foods. The types of foods that have been identified by several different groups as aggravating their symptoms include spicy and highly fatty foods, foods that increase flatus, such as onions, broccoli, and cabbage, nuts and seeds, for some people dairy products, caffeinated foods, and some fresh fruits, such as strawberries, apricots, and alcohol intake, more in women actually than in men. Patients with fecal incontinence, especially those with more liquid stools, may benefit from taking supplements of soluble dietary fiber. There are now a couple of very well-designed randomized controlled trials showing that supplements of psyllium fiber reduce fecal incontinence. Small amounts, starting at 2 to 3 grams of psyllium per day, may be sufficient for some individuals, and dosing should start at this lower amount, but others may need more. And in one study, up to 16 grams per day have been tolerated. For patients who take antidiarrheal medications regularly, though, one study showed that individuals with fecal incontinence of any consistency who took a psyllium supplement of about 3 grams per day, in addition to taking loperamide of 2 milligrams per day, did not improve their symptoms of fecal incontinence more than those just taking the antidiarrheal medication alone. So dietary fiber may be at the level of anti-motility medication and doesn't have an added benefit for some patients. In terms of lifestyle modifications, even though nicotine is thought to stimulate bowel motility, there really is a lack of evidence in studies about quitting smoking and reduction of fecal incontinence. However, smoking cessation is recommended for better general health. And regarding weight loss, observational studies suggest an association between obesity and fecal incontinence. Some of that association is that more women with fecal incontinence were obese and overweight than women without fecal incontinence. Obese women with fecal incontinence had higher anal resting tone at baseline and squeeze pressures by manometry compared to normal weight women, suggesting a lower threshold to leakage with greater pressure. And we know that weight loss has reduced urinary incontinence. But to date, the evidence about the effects of weight loss for fecal incontinence is mixed. Women with dual incontinence who lost weight from a dieting program, including high-fiber food, had improved urinary incontinence, but no difference in fecal incontinence between two groups, those who were not part of that program. And weight loss after bariatric surgery has not consistently been associated with lower fecal incontinence. One study actually showed an increase in anal incontinence of about 12% after an average weight loss of 40 kilograms. Another conservative management recommendation based mainly on clinical experience is for the patient to try and establish a regular bowel pattern, but there's little evidence on how to actually best achieve a regular bowel pattern. For patients with defecation urgency, bowel training, similar to bladder training, may be helpful. And in bowel training, the aim is to have a more controlled bowel movement using relaxation and progressive delay in defecation. There is no standard protocol for bowel training, and so the ICS Nursing Committee is actually engaged in developing a best practice consensus document for this intervention that hopefully we'll be seeing by the next ICS. Transanal irrigation is a strategy that has been shown to be effective in reducing fecal incontinence in patients with neurogenic fecal incontinence, and some patients with non-neurogenic fecal incontinence, those with incomplete evacuation or difficult defecation, also report decreased leakage from rectal irrigation. Irrigation clears the rectum of feces, and the idea is there's nothing left in the rectum to leak in the short term. And here you see on this slide a couple of the portable transanal irrigation systems that are available for patients to use. There are a few studies about the effectiveness of some of the other rectal emptying strategies that some patients use, such as using a suppository, abdominal massage, or taking senna and prunes. And I think we're establishing a pretty good beginning for some of the evidence for transanal irrigation. Clinicians are recommended to ask patients about using complementary therapies for managing fecal incontinence, as there are now reports that some patients do use them. They consider them safe and natural. The most common one for GI problems are taking herb mixtures or a probiotic, and here you see a list of some of the others that have been used. The research on the use of complementary therapies for fecal incontinence is just in the beginning stages, with case studies showing both positive and negative outcomes. There was one case showing a positive outcome with an herb mixture and probiotics, and another one showing a negative outcome when trigger point acupuncture was used for pain in a patient with MS and fecal incontinence then developed. And I think this is an interesting direction for those patients who are not responding to our other conservative therapies and is in need of additional research. Because the greater share of fecal incontinence management does require self-management by the patient, patients and caregivers desire advice on practical approaches. A consistently identified need is to better understand the variety of absorbent products that are available to contain fecal incontinence. There are now some resources available to inform patients by these. There's a continence product advisor website for both patients and clinicians that can be accessed through the ICS website, and there is an Ask the Expert table tomorrow about use of that website if you're interested. On the nursing page of the ICS website, there's also a library of resources, and in that library are some short, there's a one-page handout of the main types of absorbent products that you can download and provide to your patients. It's free, that describes the absorbent products in general, brand neutral. Advances in absorbent products have informed their effectiveness for UI. We have seen that over the years, and liquid FI. These products are important to patients that enable them to work and socialize, but they need a better design for fecal incontinence. Here you see recommendations of community living patients with fecal incontinence about how absorbent products can be improved for fecal incontinence. Patients said they need better protection from skin damage in contact with softer feces and particular irritants, even in more liquid feces. They need better odor control. They need better absorption in the back and containing larger leaks without being bulky. And they want them easier on and off in case they would need to change in public restrooms. Speaking of public restrooms, we know that the location of the nearest toilet is an important coping strategy for our patients with fecal incontinence. Useful information to provide your patients are information about the several mobile apps that can be used in locating toilets and even planning routes. Some patients benefit from simple tips such as preparing and carrying a small kit for cleansing and changing that can help lessen their anxiety Often men don't think of preparing these type of kits. Some patients report that modifying eating patterns to reduce intake before going out to public is helpful, and older adults may benefit considerably from continence aids such as a commode or over-the-toilet chair in their homes. And lastly, for my part of the presentation, I'm going to cover several products and devices which block fecal leakage from the rectum that are now available. The anal plug is made of soft foam-like material and expands like a tampon in the rectum. The anal insert has a different design. It's made of silicone, and this disc is actually outside the rectum, and this one is inside. This is a one-time use device, whereas this one can be used a second time. A new device is the vaginal bowel device. It acts as a mechanical barrier but uses a different approach. These two are inserted into the rectum. As you can see here, this one is inserted into the vagina, and when the balloon is inflated, it compresses the rectum closed from the vaginal side. And actually, Dr. Richter, who's one of our speakers, has been involved in testing this new device. And even though it looks like I have more cons than pros on this slide, I do want to say that use of these products and devices has been very effective for many patients temporarily and can improve quality of life. The cons depend on the device. The anal plug has been reported to be uncomfortable for some patients. The vaginal bowel device has a higher comfort, but again, it's for women only. Both the plug and insert may be accidentally expelled. The vaginal bowel device does need to be fitted by a clinician, and some women may report some discomfort, urinary incontinence, or bleeding when it is first used. But despite their limitations, it is very helpful to have these in our toolbox of therapy options that we can offer to patients as needed. I have provided in the online work a number of references that this information has been taken for that I'm happy to share with you. So thank you very much.